neuroendocrine tumor of pancreas. Age, which is normally that shows is between the 45 years and affects males and females equally. 90% of the insulinomas are benign and 90% are sporadic. Only 5 to 10% are associated with MEN1 and are familial. They're distributed equally in the pancreas. Rarely, we can also find them in duodenum, splenic hilum, and gastrocolic ligament. As mentioned, Whipple's triad was evident in our case also, where neuroglycopenic symptoms appear due to hypoglycemia. Low plasma glucose is seen during the symptoms, and the symptoms get corrected as soon as the glucose is administered. 72-hour fasting is the gold standard for diagnosis, and biochemical parameters and the localization of tumor are done commonly nowadays. So how do we localize insulinoma? Usually we start with CECT abdomen and MRI, but the sensitivity of both is between 70 to 90%. Then EUS helps us to get better picture of smaller size insulinomas. 90% is there in the sensitivity in the pancreatic tumors. However, it is less in the duodenum. Then we have SRS and SPECT-CT and gallium dotanol, which has less role to play in insulinoma because of the lack of somatostatin receptors. Selective arterial angiogram is also helpful, but it is rarely done, and so is intra-arterial calcium stimulation with hepatic and portal venous sampling. Usually the best is exploration and intraoperative ultrasound. So surgery for insulinoma is usually enucleation because 90% of the times it is benign. In case of metastatic insulinoma, we can start with stomatostatin analogs. Hepatic artery embolization of the liver mets are there. Streptozocin and 5-fluorouracil can be given, and diazoxide is also used. So a few words about MEN1 syndrome. The MEN1 syndrome, germline mutation of MEN1 tumor suppressor gene is usually on the long arm of chromosome 11. It is an autosomal dominant disease with 100% penetrance, affects males and females equally. The common neoplasia associated with MEN1 are parathyroid neoplasm, which is 90% of the times, which is multiglandular. 30 to 80% of the times pancreatic NETs are present. In that, non-functioning is more common than the gastrinoma, and insulinoma comes after the gastrinoma in the levels of occurrence. And 15 to 30% pituitary adenoma is also present. In that, most common is prolactinoma. 30% of the times adrenal corticonodules are also present. Thymic and bronchial carcinoids are present. Lipoma, cholangioma, facial cutaneous angiofibromas, and meningiomas, ependymoma also may be present. So NET in MEN1 syndrome is different than the sporadic NEDs. It usually occurs in younger age. It is multifocal, and it is shows high propensity for malignancy. Like gastrinoma shows for 75% and insulinoma 10%. And glucagonoma will always show 100% chances of malignancy. And mortality in MEN1 is due to malignant peanut tumors. In the germline mutation of MEN1, how we do the testing and screening? First, index and first degree relatives are screened. At the age of 5 years, serum prolactin is done annually. At the age of 8 years, serum calcium and parathermone is done annually. And starting at the age of 20 years, serum gastrin, proinsulin, and glucagon are done annually. So this is the picture of distal pancreatic splenectomy, where the distal pancreectomy is done, and when we want to preserve the spleen, we try to preserve the blood supply with the splenic artery and the splenic vein if it is just a small tumor and if it is possible to resect. However, if the splenic artery and vein cannot be preserved, but we want to keep the spleen, we want to preserve the spleen, then we can divide the splenic artery and vein, and on the short gastric vessels, which you can see over here, and left gastroepiploic artery, the spleen can survive. This was a method shown by Warshaw, which is very helpful in spleen preserving pancreatectomy. So this case was discussed in this forum because insulinomas are usually sporadic. They are subcentimeric and solitary lesions, but here it was large in size and it was multifocal. Dotanox scans usually don't pick up these, and insulinoma doesn't have uptake, but here it had an uptake. MEN1 is a rare entity, and MEN1 is frequently present with gastrinoma, but here it had insulinoma as its presenting peanut. So, thank you. Sir, that the OPD paper did not have neurology, the blood sugar levels documented by the neurologist. It was actually done outside. All the 3 episodes of seizures, sir, were tackled outside by a neurologist, and then after the 3rd episode, he came to our this thing. That also to endocrinology department. So after all the Dotanox scan and all, we got the patient in our. Sir, it wasn't showing any uptake. Probably it was a non-functioning adenoma which was accidentally picked up, sir. And it, yes, sir. Yes, sir. Yes, sir. That already we spoke with the endocrinologist. Actually, the patient was basically with the endocrinologist. After this surgery, they had planned immediately for parathormone also, because this was threatening more. So we first tackled this one, and then the parathyroids were also tackled with the other team, general surgery team, sir. So there were no ulcer symptoms, there were no abdominal pain or any symptoms. Just the presentation was with seizures only, and upper GI endoscopy was not done, I think, sir.
Any medical gastro opinion obtained, and US was suggested for him. After the CT,
Yes, sir.
you directly went into
Dotanox scan. Yes, sir.
So based on the clinical.
And sir, because we could localize with the Dotanox scan, so we did not go ahead with the US. And because the hypoglycemic episodes were very alarming, sir, luckily he was in the hospital, so we took up for surgery because we could localize the tumors, sir. That is why. And intraoperatively, we did an ultrasound actually. We palpated the pancreas after mobilization, and intraop ultrasound was also done, sir.
So
we skipped the US.
US can also give better
yes,
vascular relation to the tumors,
yes,
and prior to the surgery itself, we can plan the surgery.
Yes, sir.
Involvement of splenic vein and other things, so that
yes,
you can
sir.
plan before.
Yes, sir.
I think you got very lucky that it was a very well localized insulinoma, because most often they're not difficulties localizing where it is.
Yes,
it was all nicely actually given, so maybe it made it easier.
Yes,
Slightly unusual of an insulinoma, like you've already pointed out.
Yes, ma'am.
I want to ask any question? Can I ask? I mean, was there anybody experienced difficulty in localizing? Because I had an opportunity of in the past few years, 8 cases suspected. As he said, EOS was done, 4 we could localize, but 4 MRI didn't pick up, CT didn't pick up, EOS also couldn't pick up. And it was very, very small, so whether to target it or not, it was very small, 4 mm, 5 mm. So, how far you stretch your evaluation? Because one patient we were planning, he was very high professional, you were asking him whether you can do an arterial stimulation test, which radiologists were not very keen. How much you push? Another thing is offshoot of this case. What is the value of parathormone which you consider significant? Because we had 2 cases of pancreatitis, no other etiology found. Normal value parathormone 65. That fellow had 87 or 90. So my endocrinologist said you do vitamin D, and if it's low, and it could be secondary. Every patient has vitamin D low. And his calcium was 8 to 10 was normal. His calcium was 10. So these two. Look at your calcium is 13. So that's what happens. So majorly acute pancreatitis will have a high PTH anyway. But if you have something like 220, correlate with the calcium. Generally, when you have a parathyroid, the calcium levels are pretty. You don't get 8 and 10 or something. In the neuroendocrine tumors, one of the reasons why we do an endoscopic ultrasound is that when we do an FNAB, now we go to FNAB. And if you find that your K1 cystosis is more than 5 or 10,
Okay.
then a PET scan alone will do. We don't need to do a Dotanox. Sometimes we pick up mets in a PET scan.
Okay, sir. Yes, sir.
For patients who had difficulty in localization, on-table ultrasound will be a better choice rather than endoscopic ultrasound.
Yes, sir.
Well, the question arises when we don't have a free of diagnosis at all. There's no, as you said,
Correct.
it's a very lucky scenario. We don't pick up, and if you pick up, it's 3 centimeter, which is
Yes, sir.
normally it doesn't
Yes, sir.
So what to do in such cases? We know it's a biochemical instrument.
Yes, sir.
But where's the